Good morning. Today we're going to give you a presentation on chronic obstructive pulmonary disease, also known as COPD. These are some of the things that we're going to be covering today in our presentation. Some quick facts about COPD. It is estimated that more than 250 million people in the world have COPD, and over 65 million of these cases are considered moderate to severe. The World Health Organization classified it as the fourth most common cause of mortality in the US and third worldwide. And it's also the fourth leading cause of disability. According to the CDC, COPD is associated with $32.1 billion and is projected to increase to $49 billion by 2020. The pathophysiology of COPD. COPD is a progressive and life-threatening condition that affects the lungs and the patient's ability to breathe, ultimately leading to poor gas exchange and inadequate airflow. Some complications associated with COPD are hypoxemia, acidosis, respiratory infection, heart failure, dysrhythmias, and respiratory failure. The two main disorders associated with COPD are emphysema and bronchitis. Emphysema is known as a disease of the alveoli. It is when the fibers that make up the wall of the alveoli become damaged. This occurs due to additional enzymes known as proteases being produced because of irritants such as smoke from cigarettes. These enzymes help destroy the foreign particles found in the lungs through inhalation. However, when they become oversynthesized, the enzymes begin to damage the alveoli and small airways of the lungs by breaking down the elastin, thus not allowing it to fully expand or recoil as needed. This eventually results to fewer alveoli being available for gas exchange due to them either collapsing, narrowing, or becoming completely damaged. The alveoli that remain often are flabby and not fit for proper gas exchange. As a result, this leads to an increased amount of air being trapped in the lungs and hyperinflating them. The hyperinflated lung therefore increases the pressure on the diaphragm, causing it to flatten out and trigger the patient to use accessory muscles such as neck, chest wall, and abdomen to breathe. The patient eventually becomes air hungry as the need for oxygen increases. The body begins to compensate by increasing the respiration rate, but this ends up leading to an excessive amount of carbon dioxide retention and chronic respiratory acidosis. A little bit about chronic bronchitis, also known as an inflammation of the bronchioles or bronchi that is usually caused from irritants. Not only do these irritants cause an inflammatory response within the lungs, but trigger vasodilation, mucus edema, congestion, and bronchospasms. This increases the amount of mucus being secreted and contributes to chronic infections because the number of sites of mucus secreting glands increases. Therefore, this excessive mucus ultimately leads to impaired airflow and leads to respiratory acidosis with evidence of hypoxemia. Some risk factors associated with COPD. Cigarette smoking is known to be the greatest risk associated with it. Other risk factors include exposure to pollutants from home and workplace, such as secondhand smoke, dust, fumes, or chemicals. Some risk factors associated with the environment are poor air quality, asthma, a genetic makeup known as alpha-1 antitrypsase deficiency, and this is when the enzyme that allows the enzyme known as protease that inhales the pollutants in the lungs also start to affect the lung structure itself. Females are more likely than males. The age, with increase of age, so over 65, you have a greater risk. American Indians and Alaskan Natives and multiracial non-Hispanics, as well as having a history of respiratory infections, makes you at risk for COPD. And here's the chemicals in the cigarette. Some signs and symptoms associated with COPD depend on the severity of the disease. So some signs and symptoms are frequent coughing, wheezing, excessive phlegm, mucus, sputum production, shortness of breath, trouble taking breaths, orthopedic position or tripod position, rapid shallow respirations, use of accessory muscles to breathe, retractions or asymmetrical chest expansion, wheezes or reduced breath sounds, barrel chest as pictured on the side, pallor or cyanosis, and they tend to be underweight or have unintentional weight loss due to loss of energy and difficulty breathing, finger clubbing as pictured on the side, and decreased ability to complete ADLs, and again for decreased energy and loss, difficulty to breathe. So a case study with a patient that had COPD is here reflected. Mr. Johnson is a 65-year-old male diagnosed with COPD exacerbation. The patient arrived to the hospital for an evaluation of shortness of breath from the doctor's office. The patient was admitted to being a lifelong 2-pack per day smoker since the age of 15 to present day. He has a history of emphysema and uses O2 therapy at home. Patient presented with substernal and intercostal retractions, respiration rate 24 breaths per minute, O2 at 90% on 3 liters nasal cannula. Patient also reported to having increasingly more difficulty breathing and performing ADLs such as eating or talking recently. Patient is sitting with the head of bed elevated and O2 was increased to 6 liters nasal cannula. His husband's at bedside and nurses are waiting further orders from the physician. Our recommendation was to continue to monitor for respiratory or cardiac changes to prevent further complications. Some religion considerations to take into place for this kind of patient is to identify stressors or triggers that trigger his smoking habit and some coping skills he has used in the past to deal with stress, and also to identify triggers that initiate a possible exacerbation in the future. It's also important to address his feelings and emotions regarding the ongoing homophobia, stigma, and discrimination regarding homosexuality and how it's affected his health. Some spiritual considerations would be to take into consideration our beliefs, custom practices that the patient might have. And culturally, the nurse must determine how the patient culture plays a role in determining their attitude towards healthcare.
In the second part of the case study, the patient's condition becomes worse and start having signs and symptoms of respiratory distress. The physician suggested to put the patient on BiPAP machine and also other methylprednisolone for the patient. First, I want to talk about the BiPAP and what the difference between it and CPAP. So BiPAP and CPAP machine have very similar functions. They both help to keep the airways open and help the users to breathe easily during sleep. The main difference between them is that BiPAP have 2 pressure settings. One is for inhalation and another lower pressure is for exhalation. So it's easier for patients to exhale. On the other hand, CPAP only have one single constant pressure to help with inhalation. So it's more challenging to exhale when using CPAP. Because of that reason, BiPAP is more preferred option for the patient in a case study with acute COPD exacerbation at beginning. The medication ordered by the doctor is corticosteroid. It's commonly used in patients with COPD. It works by inducing inflammations in the airways to help with breathing. Common side effects of the medication include edema, hypertension, headache, skin problems, GI upset, muscle weakness, restlessness, and infections. Before giving the medication, the nurse needs to check blood pressure and blood glucose, since the medication can increase blood pressure and blood sugar level. The nurse also needs to educate the patient to avoid taking certain medications with it, such as aspirin, warfarin, heparin, cyclosporine, since these medications can cause serious side effects in the body. In addition, the patient needs to avoid getting any live vaccines. In the last part of the case study, patient Johnson's status improved after treatment. He was prescribed with the corticosteroid inhaler and now he's on supplemental oxygen via nasal cannula. The priority nursing diagnosis for the patient will be impaired gas exchange related to COPD and emphysema, as evidenced by shortness of breath, subternal and intercostal retractions, tachypnea, and reduced tolerance for activities. Desired outcomes for the patient will be to maintain optimal gas exchange and be free of signs of respiratory distress. Nursing interventions for these two goals are assess patients' respiratory effort, use of axillary muscles, and abnormal breathing patterns to identify early signs of respiratory distress. Encourage the patient to perform slow, deep breathing using an incentive spirometer as indicated to promote deep inspiration and prevent atelectasis. Administer methylprednisolone ordered to decrease the inflammation in the airway to help with breathing and gas exchange. Assess patient's lung sound for wheezing and diminished sound, which indicates airway obstruction and poor ventilation. Position the patient in semi-forward positions with the head of bed elevated to increase lung expansion. Apply humidified supplemental oxygen as ordered to maintain an acceptable level of PaO2. When discharge the patient, the nurse should teach proper use of the inhaler. The steps include hold the inhaler upright with mouthpiece end down and pointing towards the patient. Generally shake the inhaler 3 or 4 times and breathe in slowly. At the same time, press the top of the canister 1 time. Hold the breath as long as you can, up to 10 seconds, and then breathe out slowly. Also, it's important to educate the patient to rinse mouth with water and spit it out after using the inhaler to prevent a thrush, which is the infection in the mouth. The nurse should also provide teaching regarding home oxygen and preventing COPD exacerbation, such as smoking cessation, smoking outside the room or in a different room that where the oxygen is not in use. Adhere to nutrition therapy. Avoid using smoking materials, candles, gas burners, and fireplace. And any open flames must be avoided to prevent starting a fire while using oxygen therapy. Avoid stressors that trigger and worsen disease. Avoid exposure to other possible inhaled irritants. That's our reference, and thank you for listening.